All right, guys, while everyone's getting settled in, we're going to go ahead and get started. So excited to introduce Dr. Cizik. You guys have probably seen her around, and probably a lot of you have worked with her over the last 5 years or so. Been with us since 2019, economics and outcome researcher, a ton of expertise that's helped the spine group over the years, and I think the trauma and other groups as well. So no further ado.
All right. Turn on the mic. Okay, that's the one that was special. Okay, can everyone hear me? Okay, I don't know how many people actually do know me. I feel like I started here in October of 2019. Then, of course, we all went into lockdown, and especially those of us who are PhDs, I feel like unless you work directly on projects with us, you may not know who we are. So I am going to, last year was the summer of Taylor Swift. I have a teenage daughter, so I'm going to give you a bit of an Eras tour of my career. I've been in orthopedics almost 20 years. And so I'm just going to go through, that's my little version of an Eras poster for myself. Talk about kind of my motivation for my research, how I got started, and then we'll kind of do a past, present, and future of the work that I want to do and am doing. Okay. So this is my training background. I got a PhD from the University of Washington in 2016 in health economics and outcomes research. That was in the School of Pharmacy. It was called the Pharmaceutical Outcomes and Policy Research Program at the time. It's now been called Choice. Prior to that, I got an MPH from the University of Kansas, and then probably unusual from a lot of PhDs you've worked with, I actually was in a 6-year BA/MD program at the University of Missouri, Kansas City. So I have pretty extensive clinical knowledge. I also grew up with a mother who worked at Barnes-Jewish for almost 40 years in nephrology, so grew up kind of in a medical family, had the goals of wanting to be a neonatologist, but asked too many questions in med school and realized I needed to go do some research. And it was better suited for how I like to work. So I was a staff scientist for 12 years. I didn't get my PhD till a little bit later, and then was brought on as faculty at the University of Washington. And Dr. Brodkey and some of the spine docs got to know me through some of the research I'd been doing at the University of Washington and asked me to join the department here. So I made the trek here, and I've been very happy. So the motivation for my research, I think, really started while I was working on my PhD. And we'll go through kind of what I did in the past prior to my PhD, but I had had a lot of biostatistics and epidemiology, and was really, as a staff scientist, worked primarily with the sarcoma service at the University of Washington, and then transitioned to the spine service, and did a lot of data analysis. I think one of the motivations to go back and get my PhD was the ability to be able to write grants and really come up with questions that I felt, we could improve the things that we were studying. We looked at a lot of risk and complications. So as I'm sitting in the classroom in my health econ class, you get a book, and it's called Cost Effectiveness in Health and Medicine by Martha Gold, and it's kind of the Bible of health econ. And there's this quote in there that talks about a representative sample of fully informed members of the community are better able to recommend societal preferences for certain health states. And the fully informed members of the community really struck me, especially when we think about doing surgery. How can people have the knowledge and the expertise in the background that you guys trained so many years for to be able to understand certain health states and what is best for patients? So clearly you're experts, you've studied to be experts, but can you truly be an agent of the patient when you may not know their preferences? And how can you understand and know what a patient preference is? And so that really got me more into the idea of outcome measurement and patient preference research. So during the pandemic, I did a little professional development, and part of that was we should write a purpose mantra and kind of what. And I think, especially for the residents, as you go out in your career too, it's really easy to get distracted. And those that work with me, senior mentors will tell you I'm easily distracted by projects. And so having a purpose mantra helps you understand what you're going to do and what you're studying, what projects you want to be involved with, because there's lots of opportunities, right? There's plenty of research and plenty of questions to answer, but how can I hone and really focus on a research trajectory? So I'm here to improve healthcare inefficiencies through the framework of value-based healthcare. To do this, I want to do things using patient-reported outcome measures, health economics, and shared decision-making. And kind of the tool or the approach that I want to use to do this work is collecting and using the data that we do with patient-reported outcome measures. And the hope is by using those measures, you as surgeons and the patients can make informed patient-centered preference surgical care decisions. Okay, so when I say value-based healthcare, shared decision-making, PROMs, what do I mean, right? People throw these terms around, I'm sure you've all heard them. What does that mean to me as somebody who's trained in this field, and how do I want to use that to define my research? Okay, so value-based healthcare. So this term has been around for a while. Probably all of you have hopefully read the Michael Porter paper that really kind of reinvigorated this idea and brought business into healthcare, and we can have a whole nother discussion on whether that was good or not. But I think there's important balance. And so what do we mean when we talk about value-based healthcare? Well, it's this idea that the patient's at the center and everything else kind of, it's the hub of the spokes, and then the spokes are all the other things in healthcare. So if patients participate in value-based care, the idea is they're going to end up with lower costs and better health outcomes. If providers participate in value-based healthcare, hopefully they're going to have patients that have higher satisfaction. We know that's not the case. And better care efficiencies. So again, I think one of the goals, and I'll talk about this later in the talk, is I don't know how many people have heard the term integrated practice units, but this idea that, boy, wouldn't it be great if all the patients that came to your clinic were all surgical patients? Wouldn't that make your day? Every single patient came in and you signed them up for surgery. And we know that's not the case. So there's inefficiencies with the patients you're seeing and how they're getting referred. The payers like this because it controls costs. There's certain bundled payment models that are gaining traction, and it reduces risk. If they can have outcomes and quality targets, it reduces risk. Suppliers like it because you can align prices with patient outcomes. And overall, the societal benefit is, boy, wouldn't it be great if we reduced healthcare spending and everybody had better care. Okay, so CMS defines value-based healthcare with an emphasis on integrated care, meaning providers work together to address a person's physical, mental, behavioral, and social needs. And when I read that, the first thing I think of is, oh my gosh, we have PROMIS measures to measure every single one of these things. So I think this is why we should be doing this. This is going to happen, and we're going to talk later. For those of you that aren't aware, CMS is requiring this for inpatient total joints starting this month. So we have a call to do this. This graphic I made for part of my dissertation, and we'll talk about what that was, but this idea, again, that by doing this, we can have the surgeon, the patient, make decisions together that benefit both the patient, and it's the right treatment for the right patient. And then again, if we do that, then the societal costs are met and resource allocation improves. So what do we need from people to do this type of value-based healthcare? Well, it has to be patient-centered. The patients have to be willing to engage in this as well. So they have to be a collaborator. And we know that can be difficult too. And they need to ask questions. And you need to be able to get those questions because they don't know what they don't know, right? And then the provider needs to engage in this to be able to, again, decrease those inefficiencies. So reduce fragmentation. And be willing to be evaluated on the quality of your care, right? And this is where we talk about, well, we want to have risk adjustment and things like that for the patients we take care of. And also be monitored on your patient's individual health outcomes. And again, how can we do that? We can do that with patient-reported outcome measures. Okay, so shared decision-making. When I think of this, and it's interesting, so my training was very health economic and econometric, and so we'll get into that a little bit more, the approaches of these, but thinking of things like conjoint analysis, using multi-attribute utility instruments. Those are MAUIs, direct assessments, standard gamble, time trade-off. So that's what I was trained to do, and I can do cost effectiveness analysis. Well, when I came here to the University of Utah, I met with Angie Fagerlin, and she's the chair of population health science, and she's well known for decision making. She's on the psychology side of decision making. So there is this whole other field of decision psychology. And this brings in things like health literacy, numeracy, risk communication, using decision aids, and what about surrogate decision makers, which we think a lot about in trauma. So again, it kind of my past is this idea that very quantitative, heavily in modeling and data, and then being able to come here and get exposure to this other side of shared decision making. And I think we need both to do the work of value-based healthcare. And then there's PROMs. And hopefully everyone here is familiar with our VVAL. It's one of the reasons I came here is that we have, we're one of the few institutions that's done a full clinical implementation of patient-reported outcome measures, meaning that it's not just in orthopedics. You can go to a primary care clinic and be asked to fill these out. And we have, at this point, millions of assessments with this type of data. So there's PROMIS measures have domains: physical function, anxiety, emotional support, sexual health, mental health, social health. And then in orthopedics, we have a whole battery of legacy measures that are very specific to, just like we think of our service lines: joints, shoulder, elbow, hip, knee, hand. So those are all the measures that we can use to do this work. Okay, so what are some of like the approaches or methods that I use or am going to use to do the work that, to do this work? So recently, I've been starting to get into bioinformatics and data science. I'm writing a grant in this space. And this starts to lean heavily on our technology side of the operations of the hospital. So this is like our Epic team, EHR operations. With that comes some of the data science stuff of machine learning, natural language processing, data visualization, clinical decision supports, which I'm sure all of you are a fan of, getting those little alert boxes all the time when you're charting. So that's one way we can do this work. Everybody here has been exposed to various biostatistical techniques, t-test, chi-square. We still do all those, but now we can do more sophisticated modeling. Cost effectiveness, we can do things like incremental cost effectiveness ratios, so we can use our outcomes data, and then we can use our cost data. We have the VDO here. Epidemiologic methods, incidence, prevalence, those are things I work with and do. Health services methods, Brooke Martin's a little better at that than I am, but I also trained in those methods. And then mixed methods. My master's was actually qualitative focus group in urban and rural Kansas. So being able to actually go to the patients, ask the patients what matters to them. I'm starting to work on some PCORI funding, and we're doing patient engagement work and capacity building, where again, we bring patients to help us set research agendas and what are outcomes that matter to them. Psychometrics, this is the field of study that helps us develop these PROs, PROMs, and this gets into some of the work of MCIDs, minimally clinically important differences, patient acceptable symptom states. This is where we talk about IRT, item response theory. So those are some of the things I see. And then utility measurements. So again, this is more on the health econ side. We can do visual analog scales, time trade-offs, standard gamble, best worst scaling, discrete choice experiments. So lots of options for approaches and methods to do this type of work. So then you're probably wondering, okay, great, she's got all this background, but what does she care about clinically in orthopedics? Well, that has changed over the years. Because it just depends on who my collaborators are. I started in sarcoma at the beginning of my career, and again, then moved into spine. Here, I've had the opportunity to work with a lot of people. I think about it more now as elective procedures. So again, where there's equipoise in a decision, whether the patient needs surgery or not, and you're really letting the patient decide that, that's what I care about, whether it's an upper extremity total shoulder or whether it's a fracture of the femur. Again, I think fracture of the femur is not elective. So we'll go with joints. joint replacement. But again, that's what I broadly think about when I think of what is the clinical work that I'm interested in studying. It's really where there's decision-making that has equipoise, that we are really putting it into the hands of the patients now to say, here's what I think, but you need to decide if you're going to do surgery. Fragility fractures is a newer area, and I'll talk more about that. Joint replacement, I've dabbled in and out of, but we'll be writing, my K is in this space, my K01 training grant. MSK oncology, again, I did sarcoma, but here I've had the opportunity to work in osseointegration and also metastatic bone. Osteoporosis, I'm starting to work in a data set that we're getting some data with that, plus the fragility fractures. And again, keeping up on my spine and trauma work. And then I've tried to break up what are like interventional approaches. So my ultimate goal is to do interventional studies and to really figure out, for all these conditions with all these methods, how can we improve, how can we change something, right? How can we make things better for patients? So I've started to work in the space of caregiving. I have a personal interest in that. I have a daughter with a rare genetic condition and do a lot of caregiving for her across multiple specialties. And I think, oh my goodness, I'm so grateful I have the knowledge I have to take care of her, but I know not everybody has that. So how do we help people, again, gain this knowledge or skill set that then helps you help them make better decisions? Clinical decision support, I do think, is an area, and I would like to think that I'm on your side. I know you don't like getting those little boxes that tell you things, so how can we make that usable? To use data in the EMR, make it accessible, make it help you, but also not burden you and be a barrier to care. And then social determinants of health. So again, I did a lot of this work back in Kansas among rural and urban white women, Black women, and Hispanic women in mammography screening. And again, that we have the great opportunity here being in Utah to really study some of these problems, especially the virality issue. And I have a grant that's hopefully going to hit in that space. Health literacy has been another area. One of my collaborators is Tanner Heaton over here in that space. And then just thinking about access to care and utilization. Okay, so that's kind of who I am, what's really driving me and informing me. So now we'll kind of go into my past eras. And really, I was in orthopedics, and then I eventually studied health economics, had this very strong biostats and statistical and epi background for my MPH. So got into orthopedics and worked on the sarcoma service. The nice thing about my time there was how clinically involved I was. I was in the OR, I was with a PET scan, clinical trials, so I really got to know orthopedic surgery. And I kind of missed my time. The clinic was so, it really brought up a lot of research questions, being in there and seeing patients and wondering why someone with a huge liposarcoma waited so long to come in to be seen, and it was because they could no longer put their pants on. And thinking, wow, just again, how does somebody without the knowledge to know maybe I should get that looked at sooner? So again, wrote some papers, did some traditional cancer studies looking at survival, looking at procedures, megaprosthesis versus condyle-sparing interbiliary allografts. But this is where I also started to work with some measures. So this is kind of early, I'm old enough, this is right when PROMs was starting. So the SF-36 was still the big general measure. And so we validated the generic SF-36, and then at that time the SF-60 had just started to be used, and we looked at that with the TESS Toronto Extremity Salvage Score and correlated those two instruments. But again, I was attending weekly tumor boards, clinic, and surgery, so really got a lot of exposure during this time. Then I had children, and the sarcoma service was a little too busy for me, so I jumped over to the spine service. And had a really great partner in Michael Lee. He now has moved on and is at the University of Chicago, but we wrote about 12 papers together using this data set from Dr. Sohail Mirza, who had received a DoD grant and established a spine end result registry. And so that had about 2,000 spine patients that was prospectively collected with all sorts of details Brooke Martin and I collaborated back then. You can see he's on this. And so we did a lot of work in looking at risk factors and complications following spine surgery. So this was a lot of data modeling and prediction modeling. So again, I really got to know the clinical area of spine. I kind of joke, I've done these like mini fellowships over the years and these various subspecialties. So, and also I think the real learning part of doing this work was understanding registry data and what we could do with it, what we couldn't get from it. We didn't have outcome measures in this data set. That was missing. So again, we could talk about complications as outcomes, but we really didn't know how patients were doing. So then I moved into my dissertation, and this is where I went back to sarcoma to study this problem. We had two surgeons at the time who really came from different camps. One was very much into limb sparing, and the other was more into wide resection and really removing the tumor as much as possible, and decreasing local recurrence at the risk of losing function. And so I had a nice case study there to really study the two approaches and thinking about how patients got referred to that sarcoma service and what they were offered as a surgery really depended on what surgeon they saw. And so I did a study. I went to the CTOS and MSTS and surveyed the surgeons at those studies or at those societies and asked them to evaluate health states. And so they had to do standard gamble, which is a probability exercise in which health state they thought was worse or better, and they would keep doing that till they would say they couldn't decide between two health states. And so they rated these, and then I used the literature for patient and societal utility measurements, and then I did a cost effectiveness analysis. And so the results of my dissertation were, so again, thinking back to that original statement of Dr. Gold, where people need to be informed, surgeons have the knowledge, patients have the preference that they want for living their life. How do we do this? How do we do this work? And so from a health system perspective, from cost utility, there is welfare loss if the default strategy is based on the preference of the surgeon. So if a patient says to you, well, what do you think? I want to do what you tell me to do. From a modeling exercise, that is not good for societal resources, and ultimately the patient is not making the decision that works for what their lifestyle or their preference is. So on average, surgeons appeared to favor the narrow, inadequate margin surgery aimed to preserve limb function. They were required to trade off basically between function and recurrence, which I get is kind of a tough argument, but that's just how we modeled it. And the general population favored wide margin surgery that maximized life expectancy with less risk of recurrence. So again, if the average surgical strategy followed the preference of surgeons, it would produce lower health gains or quality adjusted life years for a typical patient as compared to a strategy reflecting whether the community or the patient's valuation of the health states. So again, there's these various perspectives that we think about in health economics. You have the patient, the health system, the societal perspective. And so if a health system is thinking about, well, how do we allocate things with the limited resources we have? If a surgeon's preference for a strategy were followed, it would cost society in general more than if the patient or the societal preferences were followed. Again, a modeling exercise, but very interesting to think about as we think about how do we better engage patients in preference decision-making. So my partner, Mike Lee, moved on to the University of Chicago. I was working on my dissertation, and this is where I joined the Surgical Outcomes Research Center at the University of Washington, and this was mostly led by a general surgeon who did bariatric surgery. And he had started this outcome assessment program really from a quality improvement across the state of Washington, and was looking at outcomes of bariatric surgery. And our chair at the time, Jens Chapman, was very interested in doing a spine version of this. And so when that happened, they asked me to kind of come in and be like the researcher for the spine part of it. And this was a really great exercise to kind of pull out a little bit from research and think about quality improvement, think about public policy. There was a lot of issues going on in the state of Washington with the labor and industries not wanting to pay for spine fusions and wanting to put a lot of criteria around that. And so surgeons in Washington state, and Brooke can talk way more about this too, there was a lot of spine fusion happening. And so this was a surgeon-led collaborative where they would use performance, they would set thresholds and data and variables that they were interested in to make more appropriate, safer, and higher quality spine surgery across Washington state. It was implemented across the state, so community practices were involved, so that was really fun to think about, all the resources we have in an academic center we kind of forget. And I'll talk a little bit about how we had to implement patient-reported outcomes in clinics that didn't have Wi-Fi in their, we just don't even think about it. They didn't, at the time, they didn't have Wi-Fi in their clinic, so how are we going to use an iPad to get data? But this was a great project because it really was spine surgeons driving what were the metrics and what were the thresholds and the benchmarks. And then once a year, we would have an annual conference and we would de-identify the data and present it, and everybody could look at everybody's centers. They didn't, again, know, they knew their own number, they didn't know everybody else's, and they could see what their rates of complications. And so this was just a really great way to, one, learn about kind of, again, a different type of data, a different style of research. It was very collaborative. Then a few grants happened as a result of this, and so I pretty much ran this Spine Fusion R21, where we implemented PROMs and looked at differences in various spine fusion rates. And then the last part of my past was PROMs and implementation. So really kind of during my dissertation work and kind of the last 5 years of my time at the University of Washington, I really started to get into PROMIS measures and realizing, especially for spine, and really a lot of the procedures we do, right? Like, and thinking broadly even outside orthopedics. If you think of surgery in general, we no longer, yes, people die, but not like they used to. So the outcome measurement isn't mortality anymore. It is, did we fix the thing you wanted fixed? And what is your life like now that we've fixed that? And so we need to think of a better way to measure things than our typical epidemiologic incidence, prevalence, mortality, survival, because people are surviving things. And now we need to know how they're surviving. What does surviving look like? So I did three different types of implementations. And then you can also see, and I'll talk about these last two, MEVAL and AVOS. But the SCOPE program was primarily, again, had more of this QI clinical care implementation focus, and then a registry was it was building off a platform of a registry that already existed in the state. But the environment was very interesting in that it included these community and academic spine practices. So we abstracted data both inpatient, outpatient. The measures we used were PROMIS 10, and then the ODI, NDI, and NRS. And then from that QI platform, we would get various grants and do various research studies. So that was very research-oriented and research-led, and various measures would be added on to answer specific aims on research questions. So again, the same environment, but more of a focus on research and answering specific questions. And then in my last 2 years at the University of Washington, after I had finished my PhD and came on faculty, I moved my office down to Harborview because everybody wants to be at Harborview. And really got to collaborate with Connor Clavino, one of our trauma surgeons, in the space of thinking about how do we use PROMs in trauma. And he had started a QI project, and we took that further, and we got an ORAF grant to look at pelvis and acetabular fractures. So again, that was a really different type of implementation to think about how do we implement PROMs in a busy, 70 patient day in Harborview with the type of patients, with the various traumas, the fellows coming in and out. So just when you think you've learned how to do this work, you have to learn it all over again for another service. So that was a great learning curve and really enjoyed my time, and that allowed me to then come and collaborate with our trauma team here. So I'm going to start to move into the present, but while I didn't do the MEVAL implementation, it was very different here because, and I should say too, the UW experience was that getting patient-reported outcome measures implemented, they spent years on developing a governance structure and who's going to do it and who's going to own it and who's going to do the data. And we never really got to implementation. We never actually got the measures done. And Utah had the opposite. So Utah got it done. And Utah implemented these measures. It started in orthopedics. Everybody saw orthopedics was gaining a lot of national traction for doing this work. And so then the hospital wanted to do this, all the practices wanted to do this work. And so again, that was done very well, but the governance structure was missing. There was some governance, but not to the level of now, and you'll learn now that we're in kind of this long-term era of patient-reported outcome measurement here at Utah. We don't really have a vision or a direction because some of those leaders left who were pushing for that. And now it's a little, also technology has changed. So we're going to talk about that too. And then the American Board of Orthopedic Surgery, and Dr. Saltzman and I got to know each other through this. I was a visiting scholar for the ABMS, ABOS, and I was able to look at board candidate data that was collected in the first year of the board collection period. People from various, all first-year all candidates were having their patients get patient-reported outcome measures. So again, that was another way I was looking at PROMs data, kind of with a different lens and a different focus on what we wanted to do with that data. Okay. So all that work led me to here, which is great. And so I came here to really work in this MEVAL data and learn, how can we use this data now? We're moving past research. How can we use it for clinical care and clinical decision making? So the trauma team was very gracious and let me interlope, and we got a lot of work done, and Tyler and I got a lot of work done. And so this is where we really did a lot of work in studying MIDs, minimally clinically important differences. And then kind of recently, not that recent, maybe a year ago, I was able to collaborate with a graduate student in bioengineering, and we were able to correlate some objective measurement data with PROMIS data, which was really interesting to see how those measures, and I think that's a big question everyone has. Well, this is great. The patient says they're doing this, but when I watch them walk, they're doing this. They're walking fine, or, oh, they seem to be able to do stairs just fine. And so we found that the measure actually did correlate on some load-bearing metrics, and step count and walking time were the most correlated with a patient's report of their physical function on a PROMIS measure. And then I started to also be able to work in this data and get to know it better, working with Dr. Brodke and Dr. Saltzman and Dr. Spina, just starting to think about how do we visualize this data? How do I get this data? How do I look at it? Where does it come from? And so again, this is the result. We looked at the ABOS data, Dr. Saltzman and I did, and I don't know if you can see, it's really, but this is primary total hip, and the red line is baseline physical function, and then you can see 6-month and 12-year, and those lines are almost perfect on top of each other. So, I look at some of this data and think, well, maybe we don't need a 6-month data collection. We could just do it at 12 months. But here for rotator cuff repair, you can see that it looks very different early on compared to later. This was laminectomies, I think. Yeah, lumbar laminectomies. And this was, I think, a fracture. Yeah, lateral malleolus fractures. So again, like how do we look at this data? How can we interpret it? How can we use it for clinical care? Here we did a study looking at opioid users and how do they function on these PROMs domains. This was related to all the various pain measures we have. And then Dr. Brodkey and his son Dane were gracious to include me on this project. And I've always really liked this graphic that ended up in the paper, and it's a heat map of what can patients do with the score they have. So you can see, most people can put on a shirt, even if they score less than 16, which again starts to let you know, well, that doesn't get at the upper extremity injured patients, right? So this tells you that this measure is really geared for lower extremity. But I think it starts to get at this idea of how can we use item level data on these measures to better gauge in clinical care. So again, this work allowed me to start thinking it's not just about a score, but it's about what can they do functionally. So when a patient says, after a total joint, when will I be able to go upstairs? Or how long will it take me? Or what will I be able to do? And so again, I think if you were to have this heat map and you gave your patient a promised physical function and they scored a 35, you could look here and say, let's see, stepping up and down a curve. Well, if they have a 45, most of them can do that. So that's this one. Sorry, it is so small. That's like right up here. So again, the majority of people with a 45 can do that. I've had the fortune of collaborating with our upper extremity colleagues as well. We just got I got a first author paper published just this week, which I'm very excited about, linking and doing crosswalking with a quick dash in the PROMs upper extremity cats. And Ellie and I worked on this paper where we started to think about it was a very small case series, but how could we use some item level data to maybe get at some outcomes for these patients, and thinking about the patient acceptable symptom state. So where is that cutoff for patients where they're feeling like better on a measure? And so I think, the interesting thing about doing upper extremity and dabbling in this is how different those measures are, and how much a lot of our PROMs physical function measures are really geared for lower extremity. And then I'd say here in the last year and a half, I've been able to work with Serena Sinclair, brought me on one of her osteointegrated prostheses. This is data that Tanner Keaton and I looked at over the summer, and looked at the patient-reported outcome data and performance measures that she has. And our next step is to correlate this, just like we did with the injury paper, to start to understand, do these measures really correlate with some of these more objective tests that we ask patients to do? I had a grad student, and I teach a PROMs class in population health every other year. And I had a grad student do this project, and now Sam Simster is helping me with this. We're going to do a trajectory analysis looking at prophylactic versus pathologic fracture for metastatic bone of the femur. And here you can start to see, we plotted this data. And the interesting thing about this work is methodologically, I've had to think about missing data and death, right? So we have a competing risk for these patients that they die of cancer before we can get their next PROM. And so that's taken me down some methodologic paths with some biostatisticians who do a lot of work with missing data. And our next step is to do some trajectory analysis to better figure out, what do these trajectories look for patients? So this line here is when they have surgery, and these are all pre-surgery PROMs data, and this is all post-op. So you can start to see some trends here, but it'll be nice once we do some more advanced modeling to actually put curves on these. And more recently, I've been starting to get into fragility fractures. So again, Tanner and I looked at this, Tanner brought this project. With him, he had the MEPS data set, which is a national data set from AHRQ, looking at health disparities in bone density scanning. And this was a pretty simple analysis, but it was really interesting There was a variable for non-proficient English speakers, and that actually really drove the rate of people getting DEXA screening versus not. It was not these other factors. And if you start to think about interventions, we can intervene on somebody's ability to speak English or not speak English. We can bring in interpreters, we can have educational materials in their language. And so again, I'm really trying to do studies where when we come to our conclusions, there's things that we can do to improve things. It's not, oh, these were the associations we found, and now, just, yeah, stuff we already know, but we can't do anything about it. This is something we can do. I received a small grant from the family, the CFAR, the Caregiver and Family Health Consortium in the School of Nursing, and they have, so I don't know how many of you are familiar with the UPDB, the Utah Population Database. And so that's another resource here at the university that's pretty amazing that no one else has, where you can, they keep track of everybody who lives here in Utah. You're probably now in that data set, whether you know it or not. And because of the way this data set is set up, this group was able to carve out a family data set with the idea of they took patients who had died and looked back 2 years, so they have all their healthcare utilization 2 years prior to their death, and then they linked them to their kin. So we have siblings, spouses, family members that lived in Utah. And this was a dissertation work for somebody in the School of Nursing, but now they have opened up the data set for others to use. And so I'm going to start to look at fragility fractures and dementia in this population in the UPDB. And then we're going to apply for funding to actually add the MEVAL data into this data set. So that I'm really excited, one, to learn this data set, but then the next step will be to, again, bring in our patient-reported outcome data and actually see the outcome of these patients. And again, I've said a lot about MEVAL, but there's been quite a steep learning curve for me, understanding what this data is, where it is, what we have. And again, kind of a 2-year pandemic did not help my learning curve at all. But again, Dr. Brodkey, and I've also had collaborators and colleagues, Dr. Steinberg in cardiology and Dr. Benbrook in vascular surgery, who does some PROMs work. I lead a PRO collaborative for the institution where those of us who are interested and use this data and do this research meet monthly and now kind of every other month to kind of be one, who's doing what and what have you learned? How did you get your data? What's missing? But also this collaborative has now become a resource for the hospital who doesn't know a lot about this data but manages this data. And so we've kind of become the sounding board for them as new people want to either do this work or have new PROMs implemented. Our group has been the kind of the expert panel to help with this. And I think in doing this work, what's been interesting for me is I knew a lot about implementation of PROMs. So selecting your PROM, testing it out, collecting the data, using the PROM. I think coming to Utah though, you guys they had already been doing it here by the time I got here, 2014, so 5+ years of work, more than that, 6 years. They've been already doing this work here. And so now we're in this idea of what does maintenance and evaluation look like? Like how do we maintain still collecting this data, keeping people enthusiastic, funding personnel to do the work to get us this data? And so that I kind of knew this stuff. And I would say within the last year, what's become more apparent to me, and especially as we think of technology, is the PROM life cycle from a technological standpoint. So no longer are we using these iPads in clinic. We're pushing out text messages to patients to fill out these PROMs. And we're trying to pull this data into our EHR and into our Epic system so we can actually see it. Spine has it in their notes, I know. I saw it in a musculoskeletal note recently. So again, there is the ability, but I'm curious how many, especially the residents, know you can actually find this data and pull it up in the EHR. It's in flow sheets, but there's other ways to get at it too. So that's another problem, right? There's 5 different ways to get at this data. So kind of all of this has now led, in January, I had the privilege of being accepted to attend the value-based healthcare intensive seminar at Harvard. You can see the former president was in attendance as well of AAOS, Dr. Cizik. So I felt like I was in really good company there. But it was really fascinating to learn from the business school what they think of healthcare. And while I agree with some of it, I think some of it's missing from a data standpoint. And so how can I merge that world that I've trained in that's very quantitatively heavy, thinking about the business of healthcare and healthcare operations, and how can we truly measure value? And so Dr. Lee, who runs Pressgini, wrote this article. And this is kind of the new thought, how do we reorganize healthcare? And this is kind of the call for, we need to start thinking about these integrated practice units. And what do we mean by that? We need to start building practices that are like the fragility fracture clinic, the total joint clinic that not just includes surgeons, but like they have in Texas, the PM&R docs are there. The physical therapists are there, everybody's there, and the patient gets triaged to see the appropriate provider. So again, increasing the chances for the surgeon of seeing surgical patients. So what can I do in this thing? Well, I can measure outcomes and costs for patients. I can enable and start thinking about information technology platforms that help us look at and use this data. I can start to think about bundled payments. I think that's further down the road. And then I think the rest is up to you guys, right? Like you're in charge of thinking about how are you going to build these integrated practice units, expand services, and integrate care delivery across facilities. And I think Utah's thinking about that and doing that, right? We're seeing all these different models. Our med school's reorganizing, I think, to be a little bit more focused in this area. So that being said, I'm writing a training grant that is thinking about how do we do some of this work. So my aims for this is a KO1 that's going to go into NIAMS in June, is to think about, one, what are the barriers and facilitators for surgeons and patients to use PROMs to make these decisions? And then the idea is to better design. We can pull this data in now, and this is busy because this is a prototype and I just wanted to show various partners. Do you want the graph to look like this, or do you want the data to look like this? Do you want to have some patient information here? Do you want to be able to put in inputs? The patient's BMI is this, the patient is this old, and then do you want to see the curve change, right? And then also the idea of, can we plot the patient as they go along? Can we see their predicted versus their actual, right? So I think these are some of the things that we need to do to better integrate this data into clinical practice. And then again, not making this, but then testing it and making sure it's acceptable and feasible for you guys to use, because you don't need one more thing to use if it's not useful. So that is the plan. And then the training grants, you have training aims. So the goal is to, one, get a little bit more in-depth knowledge of bioinformatics and artificial intelligence and computational methods. With this is the idea of getting a little bit more savvy, being able to be that liaison between our EHR ops people who are on the business side, who do all this programming, and you, the physicians. So just like I did in my biostat days, I was a good liaison because I had a lot of clinical knowledge, and I could be that go-between between you, the physician who has all this clinical information, and like statisticians, and I can kind of be the person who facilitates. And so I think of that role moving forward as the same for these EHR, as we build these platforms and bring in more data into the EHR, how do we make it usable clinically? Again, doing more training in medical decision science from the psychology perspective with Dr. Fagerlund. The first goal is working with Kenny Kawamoto here. And then thinking about value-based healthcare delivery. So again, working with Dr. Pelt and Dr. Bradkey as they're thinking about, how do we build and improve healthcare. I also have a partner at Intermountain Health that I'm going to work with because they're building these practices. and just being a better health systems leader and management in an academic healthcare environment. So again, how can a PhD better support the healthcare system and not just do research and then it gets put on a shelf or in a journal and it actually doesn't make its way into healthcare delivery. So my future work, I've talked a little bit about my K. Here's some areas that I have grants, ideas percolating, and part of this is me saying, hey, if you want to work with me in these spaces, let me know. So again, doing some work in trauma. I think this Corey grant is going to hit. We've heard from them twice this week. So that'll be exciting. We're going to do some capacity building for people who survive trauma. My collaborators in general surgery, but it will include orthopedic patients, and thinking about these patients as they live in very remote rural areas and thinking about survivorship. So again, quality of life after a major traumatic event. I have this project that took forever because of COVID and also because it ended up being a multi-center with UW in pelvis and acetabular fractures. That's the OREF grant. We finally have all the data cleaned. We're starting to write abstracts and thinking about what's the next grant for that project. And then fragility fractures. And so I think the other thing that's been good for me is I've felt very pigeonholed that I could only apply to NIAMS. And I've been starting to think about, well, how can I pivot my research to go after aging and go after these bigger institutes that have more money. NIAMS is one of the smaller ones. And then caregiving, again, as an intervention. You know, how can we think about caregivers in the trauma space as they are surrogates and proxy reporters for patients? So I do have a grant going in next week for PCORI on proxy measurement, especially also thinking of patients who might have dementia and aging. And then EMR data solutions. So again, I mean, this is how you guys work. This is how you do your day-to-day work. How can we make the data out of that usable and efficient for decision-making of patients and surgeons? So, all that to say, I hope this reinvigorates some of you who maybe are like, PROMs are old news. Why should you care about patient-reported outcome measurement? I think one, value-based healthcare is here to stay, and it's going to become increasingly, especially for the residents, part of your practices. We now have this CMS Pro PM for total joints. It's right now only in the inpatient for patients admitted inpatient, so we know that's a pretty small cohort, but don't kid yourselves, they'll make this for ambulatory and they'll make it and expand it. But you can see what is the implication, and if we do not collect, so you can see here, you have to collect your HOOS and COOS and either a PROMIS 10 or a VR 12, and there's an opioid question, so there's a data set you have to collect from patients. You have to get it 0 to 90 days before their joint procedure. Then you have to submit that data, and then you have to get a 1-year follow-up between 300 and 425 days. And if you don't do this on at least 50% of your eligible patients, the hospital is going to lose $1 million. And you can imagine that will trickle down, right? It won't be the hospital. They'll make everybody pay for that. So I don't think this is the first of these. I don't think it'll be the last of these. I think we'll probably see it in spine next, is my prediction. So this is going to become important, especially for those of you as you head out into your practices, thinking about how are you going to do this work? How are you going to collect data in your practices if they aren't already doing it in the practices you join? And again, this is important because it does help patients, and Dr. Pelt shows me what he does. I know he draws on a piece of paper and shows patients, you know, here you are, I can probably get you to here. And maybe he wants to keep doing that, and that's great, but wouldn't it be nice to use that patient's actual data as he's doing that and show them along the trajectory in the chart? So again, you should care because I think it can help you have conversations about decision-making for surgery, and for sure it helps you track a patient's outcome in terms of pain and function. And that is it. I think we have a few minutes, 3 minutes. Any questions, comments? Yeah?
Thank you. It's an enormous amount of work and really impressive kind of journey that you've taken sharing with us.
I always, when I'm thinking about publishing a study, and I think you thought about this as well, I always worry, okay, I want to help patients, I want to help the system, and I don't want someone else to use this data to make things harder for patients or for us. That last slide you just had up really makes you think about that, right? Like, how is this data going to be used? And can we use this to promote the health of our patients and the health of our system? Or is it going to be used to penalize us? And how do you weigh those benefits and cons? Yeah, I'm glad you asked this question because I think that's what's been interesting is I care about the surgeon perspective. And I hope you heard that, right? I didn't spend a lot of time talking about plenty of people are out there doing patient engagement work and policy. But I think often in this type of work, people aren't listening to the healthcare providers. And so I do think about that when I write papers, right? Because we know that this data has been taken when we publish these MCID papers. I want to make sure the methodology is sound, and do I really believe a change score of 2 or a change score of 4 or 5 is the true value? Because somebody may take that paper and say, okay, all patients for, L3, L4, 5 lumbar fusion have to make a 4-point change, or you can, if they don't, then we don't pay for their surgery, right? So I think it's really important that and it is interesting because they are going to look at this idea of substantial clinical benefit. And again, I'm still learning this, and we're building a platform. We're migrating our MEVAL data from our joint service into Epic and MyChart. So there's a big technological thing that's even happening just to do this work. But yeah, thanks for that question. So yeah, that's why I like collaborating, right? Because I don't want to put data out there that you go, great, now they're going to penalize us for that. Anything else? Okay. We're gonna